is probably the least interesting. We're gonna go ahead and start the webinar. I'm sure people will still be joining, but I'm Allison Newman at the University of Washington Addictions, Drug and Alcohol Institute at the Center for Community Engaged Drug Education, Epidemiology, and Research. And today we'll be talking about results from the 2023 Syringe Services Program Health Survey. Caleb, do you want to introduce yourself?
Sure. I'm Caleb Banta-Green, and I work with Allison. I'm the director for our CDR Center, and I'm a research professor in the Department of Psychiatry and Behavioral Sciences.
So just a few webinar logistics. This is Zoom webinar. Only panelists and hosts can share audio and video. You can put your questions and comments in the chat and Q&A. Be curious and polite. And if you're with the media, please send us an email if you plan to report on this webinar. It's just nice to have a heads up, and we like to see where the information is being shared. Also, just to FYI that the webinar is being recorded and will be posted later today, and that will be going out to everyone who registered for the webinar. So I like to start with a big thank you. This is a real team effort, both with us at ADAI, our partners at Public Health Seattle and King County, with the Washington Department of Health, who were able to get us gift cards for survey participants. Most importantly, a huge thank you to the participants who took the survey and everyone who conducted and hosted the survey. So there's really, like I said, a huge team effort with us and Syringe service programs throughout the state. Also, big thank you to Allie Lennox and Susan Kingston for their hard work on this project. They sent out all the surveys, did all the data entry, were really essential in the work. And thank you to the Washington Healthcare Authority for funding CDR to coordinate this work, conduct analyses, and disseminate findings. However, just to note, the opinions and information shared here are ours and not those of our funder, HCA. So who or what is CDR? CDR is the center that Caleb and I are a part of. This is just a little snippet of the range of work that we do. The Syringe Services Program surveys are something we do every other year. You can check out our website to learn more about past years, which we'll go into. We also do this Transforming Our Communities gathering every year, which is a conference where we learn about harm reduction, substance use disorder, health of people who use drugs. Also coordinate the Washington State Community Drug Checking Network and the Community Law Enforcement Aligning and Response to Substance Use. This is just a few of the projects that we do. Figured we would take this as time to really share the range of work that we're involved in. So if you want to check out past year surveys or find this year's survey, we do compile it in one place. We have been doing the survey since 2015, so you can check on past years, see what questions we used to ask. We've also been doing qualitative interviews every other year with people at Syringe Services programs. Those are posted here. And Susan Kingston does a really wonderful report describing Syringe Services programs and how they operate in Washington State. So as you can see, we have the surveys going back from 2015 all the way to now, 2023. It's just nice to be able to show how things have changed over time and get an example of the type of questions that we ask. So, oh yeah, let's see, qualitative. I put in a lot about our center, I guess. So, the qualitative interviews we did in 2023, where we interviewed people who use fentanyl. In 2021, we interviewed people who use meth. And in 2018, we interviewed people generally about their health. So enough about other stuff that we do. This year, our survey, we recruited people from harm reduction programs, so at Washington State, so from syringe service programs. Participation was voluntary for programs and people taking the survey. We offered a $10 gift card for participation. Those were provided by the Washington State Department of Health and were for grocery stores. This year's survey includes 1,667 people who used at least one drug in the past week. We ended up dropping 53 surveys for people who hadn't used drugs in the past week. This may be people who, were coming to pick up supplies for someone else. There are a lot of reasons people might visit a syringe service program and not be using drugs. However, for the purpose of our survey, we didn't need their information. Next slide. If you want to share this information, if you are a Syringe Services program or anyone and want to share this information in a digestible format, we did create a participant summary that we hope is easy to read and easy to print. So definitely check that out if this is something that you want to share back with other people, either for program planning or if you're a Syringe Service program and want to share this data with your participants. So we had 24 organizations participate. Some of them had been doing the survey for a long time. Some were newer. You can see that they're from all across the state, which is very exciting. And yeah, really, really happy with the turnout from this year's survey. So here's our map. There's a lot of dots. However, the great thing about it is it does show the wide geographic spread of the survey. For demographics, you know, about 2/3 of people were male, with a small minority of people who were trans or non-binary. The majority of people were 30 or older. Majority of people were white. However, we had significant minorities of people who were Black or American Indian or Latino Hispanic. Really notable is that 55% of people were homeless and 25% of people had temporary unstable housing. So a really large percentage of the people that we talked to were homeless. Most of the people were having heterosexual sex. Just important to note. Next slide. We asked about incarceration, so whether people had been in jail or prison in the past year, and a third had been. And among those who had been in jail or prison, 23% were offered naloxone on release, and a minority were offered medications for opioid use disorder on release. So we ask this because there's a lot of evidence that people leaving jail or prison are at a really high risk for overdose during the weeks after they're released. So it's really important that we do connect people to medications, and there's starting to be more funding to support that for people leaving jails. However, this slide shows we still have a long way to go. So we asked a lot of questions about what substances people had used in the last week. Methamphetamine and fentanyl were by far the most commonly used in the last week, and were the most likely to be identified as someone's main drug. 39% of people identified methamphetamine as their main drug, and 39% of people identified fentanyl as their main drug. You know, almost everyone had used meth in the last week, and 61% had used fentanyl in the past week, with smaller proportions of people using powder or crack cocaine, heroin, and benzodiazepines. Really important to note is, you know, heroin is only 16% of people, which is a really, really big change from the previous survey. Really large proportion of people using fentanyl. And if you have questions, clarifying questions as they go along, please enter them into the chat or Q&A. I'm happy to answer them. And then other questions, just put them wherever. And if they're big questions, we'll save them to the end. We hope to have time for questions at the end. So while most people used both drug classes, patterns varied by self-identified main drug. 35% of people had used only stimulants in the last week. 59% had used opioids and stimulants, and 7% only used opioids. When you break this out by main drug, if your main drug was fentanyl, 88% of those people had used stimulants in the past week. If your main drug is meth, 27% had used opioids in the past week. So really big differences based on main drug. Oh, I see a question I am going to answer now. Is it possible to get results just for King County? There is a report from King County that I will dig around and put in the chat once I find it. For other counties, you have to reach out to that Syringe Services program directly and get their data. We only report on statewide data, and those programs each own their own data. So sort of two parts. I'll find the King County report for you. And if other places want their local data, please reach out to the relevant Syringe Services program. So drug use in the past week. Methamphetamine among people who used it was used an average of 5.5 days in the past week. Fentanyl, 6.1 days in the past week. a lot of people were using 5 to 7 days in the past week for methamphetamine. About half of people used fentanyl 5 to 7 days in the past week. So really frequent use of these substances, much less frequent as we get into the other drugs. This, I found the results of this question very interesting, but maybe not surprising. We asked people, how might your main drug use change if you had stable housing? We asked them among those who had only temporary or no housing. 25% of people said they would quit completely, and 43% of people said they would use less. Some people said they don't know, some people said they would stay the same, and 2% of people said they would use more. Caleb, do you want to add to that?
Yeah, I actually got asked an interesting question by somebody about this, and they asked me, oh, does that mean that drug use is voluntary? And my response to that was, no, for folks who have substance use disorder, it's not voluntary or volitional. But there's two things that, for me, that are behind this response. One is that the reasons that people use trauma, physical pain, emotional pain are really exacerbated by being homeless, and there's a lot of triggers, and there may be other folks using. And also that when they have housing, they're better able to engage in physical health, mental health, and substance use disorder treatment services. So I just want to note that I thought it was a good question, and wanted to share that with you, that this impact is really about, I think, less of the triggers and pressures around that cause use, and also the better ability to engage and stabilize folks' lives and engage in other services and reduce the use once they have housing.
Yeah, I think that's a really important distinction. That it's for many of the people we talk to, especially if you're looking at the people who are using 5 to 7 days in the past week of methamphetamine and fentanyl, many of those people likely have a substance use disorder and are using despite significant negative impacts of their use. So yeah, it's not so easy to stop, but it's extra hard to stop if you don't have somewhere to live. Next slide. Really, really big change from the last survey, which we've seen a huge increase in drug smoking. Just really, really big change from previous surveys, and we've been hearing from our partners at certain services programs that just an enormous change in how people are using drugs. 52% of people only smoked. 89% of people had any smoking. 36% of people both smoked and injected. About half of people had any injection, and only 10% only injected. So it's important to note these are at syringe service programs, so places where people can access syringes. Some of those places have safer smoking supplies, some of them don't. However, the strength and potency of fentanyl allow it to be much easier for people to smoke, whereas black tar heroin was more difficult to smoke. So this isn't necessarily due to a change in what supplies are offered. It is really due to a change in the drug supply and in the ease of smoking it. So this is, I think, really important to note that it's really documenting a big shift in how people are using drugs. This also varied by someone's substance use. Among people who used meth in the past week, slightly over half smoked only. 29% smoked and injected, and 13% injected only. Among people who use fentanyl, 82% of those only smoked it, with 10% smoking and injecting and 7% injecting only. So if you're trying to reach people who are using fentanyl, they're likely smoking it. So many of the programs that we work with are now providing safer smoking supplies. What this looks like can be foil, glass pipes. Those are the main things. So we wanted to learn more about what that looked like. At SSPs with safer smoking supplies, 84% of people who smoked drugs in the past week had gotten supplies at their SSP in the past year. At SSPs without safer smoking supplies, 90% of participants who smoked drugs in the past week were interested in getting safer smoking supplies at their SSPs. So the other good thing to look at is we compared those with and without smoking supplies and the percentage of people who'd smoked a drug in the past week. And they're not super different. We can't really disentangle what's driving it, but even at places that don't provide smoking supplies, 78% of the participants had smoked a drug in the past week. We also saw high utilization of smoking supplies and then interest in places that didn't already provide it. Oh, this is, I'm trying to decide if David's question is a clarifying question. I think I'll ask it. David Fine says, I know these results focus on Washington, but is the trend towards smoking something that's happening in neighboring states to Washington or Vancouver, BC? Caleb, do you want to answer that one?
Sure. Well, Vancouver, BC, and British Columbia has a very different drug supply. They certainly were hit by fentanyl much earlier, and they certainly have a lot of smoking as well as injecting. The Western United States patterns are really similar in the Northwest and on the West Coast. We follow sort of in this instance, when it comes to fentanyl, we've had an east to west transition over the last few years. That is, fentanyl really evolved on the East Coast and about 3 years later really hit the West Coast. And with fentanyl, we just see a lot more smoking, and that's true throughout the Northwest as well as on the East Coast. So that is really a dramatic change. And I'll just note a little bit more about that. In part, that's because fentanyl is so potent, it is readily smoked. And you use so often, 10, 12, 15 times a day, that also is going to lend itself to smoking as opposed to trying to obtain, prepare, and actually inject drugs with that frequency. Smoking is an easier, faster thing to do.
Thanks for elucidating. So yeah, just to get back to it, high level of interest and utilization of smoking supplies.
Great. So I forgot I was transitioning right there. So I'm going to take the second half of these slides, and I'm going to talk a little bit about drug checking, and I'll give some context for this. But the questions we asked around drug checking were, in the last 3 months, have you used test strips to check what's in your drugs? And you can see some sample test strips up in the corner there. And in terms of using test strips, really similar across sites. A little more than a third of folks had used test strips. We break this down into columns here. The middle column are responded to at Syringe Services programs, so places that did do drug checking on site with an FTIR. An FTIR is that fancy little machine looking there. That's a spectrometer that detects a whole array of drugs. So we have drug checking programs that use test strips that are used by staff. So staff actually test people's drugs with drug testing strips, as well as a spectrometer, and send most results for confirmatory testing that are hopefully back within about a week. So those are our sites that have drug checking programs. And the respondents, 893 of them, were from sites that had drug checking programs. So among those that had drug checking programs, not surprisingly, a large proportion said they had used drug checking. That was 17% versus 5% who were at an SSP that did not have drug checking, who obviously had gotten those services elsewhere. I'll also note that the drug checking program is a little more than a year old. Over 1,000 samples have been tested, but it takes a while to build this program up. And I think this is very important and comes up in this next question as well. It takes a while to sort of build the trust up with folks that we actually want them to bring in residue or paraphernalia for testing. We've often been giving them a message, understandably, about please don't bring substances here or residue or paraphernalia because we're trying to keep these things distinct. But in this instance, we're actually doing drug checking, and we think it's important that people bring those supplies, and I'll explain in a moment how that is legal. So we asked in the second half here, would you be interested in having your drugs tested here with a machine or test strips? And for those sites that had test strips, 2/3 said yes. Still a quarter said no, so that's important. Not everyone's interested in this. And a small proportion were unsure. A little bit lower proportion of folks said they would be interested in sites that did not have a drug checking program, but still the majority. And we are in the process of trying to expand drug checking to more sites right now. I also think that what we're hearing is word of mouth takes a while, like many months, to spread and build trust up that you can actually bring in your drugs, residue or paraphernalia, get it tested, you get useful information, and you're not going to get in trouble for that. So that's very important. This is still a process that's ramping up. But I think the takeaways is that there is interest in this, and there's still plenty of room to grow, and we are working to actively grow this program both within these sites and to try to get more sites in the state. We have about, depending on how you count, 6+ sites now that are doing this sort of full drug checking program, and we have a few smaller ones that are doing more of a light model that involves just the use of test strips along with secondary testing. So there's a lot there. I will mention, and if someone has it, maybe someone could throw in the chat a link to our drug checking materials so you can learn more about that. And we will have a webinar in about a month. Myself and Ben Beaumont and others will be talking more about our drug checking program.
Susan already put links in. She's very on it.
Awesome. Thank you. Okay. So we'll talk about overdose occurrence. So we've got overall about 29% had an opioid overdose in the last 3 months. We used to ask this for past year. This is for past 3 months, and it used to be around 20%. So this is a much higher rate of overdose being reported. And I'll also note that, as people are well aware, overdoses are more fatal than they were before. So unfortunately, a lot of folks are dying and passing away, not able to get surveyed. In other words, overdose rate is incredibly high, and this underestimates it. So you can see here, 11% of folks had 1 overdose, 6% had 2, 11% had 3 or more overdoses in the past 3 months. So very frequent and recent. A couple of things I thought were really interesting, and I really appreciate Allison looking into this. Overdoses were significantly more common among people who were unhoused versus permanently housed. So unhoused folks, 32% had an overdose versus those who were permanently housed, 21%. And even a bigger difference among those who were incarcerated. 39% of those who'd been incarcerated had an overdose versus 25% who had not. For those who aren't familiar, there's biological reasons for that, and there's a lot of research that shows very high overdose risk for folks releasing from incarceration. And we believe that's primarily due to the fact that people's tolerance is interrupted. They may come in using, I don't know, 10 fentanyl a day, and they lose their tolerance, and they come back a week later and use that same 10 fentanyl, which, by the way, is of unknown potency, but their tolerance has gone down, and they're much higher risk for overdose. That is another reason to really encourage the use of those medications, particularly methadone and buprenorphine, while people are incarcerated, to really help them bridge that really dangerous period of time when they are released from incarceration. Really excitingly, and this is work that folks back here, People's Harm Reduction Alliance, started back in 2006, and others of us started working on this in 2010, 2011. There's a lot of naloxone out there. We have 84% of respondents carried naloxone in the past 3 months. That is in a really, really high saturation rate for naloxone. And that's due to a lot of hard work by folks at the state and local health jurisdictions and harm reduction programs. That is a big deal. So I will also say that in some ways, while there's a lot of work to get more and more naloxone out there, we have a lot of naloxone out there with the highest risk folks. And it's very important to have that, but we also know clearly that is inadequate to address the overdose crisis in and of itself. A couple different information tidbits here around healthcare utilization. On the left side in the graph, this is showing the number of emergency department or urgent care visits in the past year. 58% of folks had an ER visit or urgent care visit in the last year. 23% had 1, but 13%, or 1 in 8 of them, had 4 or more acute care or emergency care visits in the last year. So that's very high utilization of these services. Some other things we looked at around infectious disease: 89% of folks had been tested for hepatitis C, 40% in the last year. Almost the same numbers for HIV testing. 30% had been tested for syphilis. We're having an increase in syphilis here locally, so this is very important that folks test for. And then a separate question, 55% of people, over half of people, said there was a time in the past year when they needed healthcare but did not go. We've asked this question in multiple cycles of the survey, and what we often hear back from folks is the reason they're not going for care is because of how they are treated by providers because they are someone who uses drugs. So this is very important that over half of people aren't getting healthcare when they need it. And then this is a new question, which I'm really glad we added, and I thank folks for coming up with this question. We asked 2 questions. Would you see a healthcare provider here at the Syringe Services program? That was 75% of people said yes. So that's really exciting. 2/3 of people said they would see a mental health counselor. And this is among all respondents. This isn't among folks who said they had mental health concerns. This is among everybody. So we have, on the one hand, folks saying they often are not, the majority of folks saying they don't go to healthcare providers to get care. And on the flip side, we have the vast majority of people saying they would like to get healthcare and mental health care at these programs. I will note here, and probably mention again in a moment, there's a lot of work that's been happening around getting access to buprenorphine at Syringe services programs, starting back in 2017 and spreading across King County and across Washington State. And more recently, where the Washington State legislature passed last year and expanded this year to create health engagement hub programs. And these are programs that provide both low barrier drop-in access to medications for opioid use disorder, but also will be adding drop-in primary care and mental health care as well. So there's a need. The need is very large, and we are beginning to try to address that need with expansion of services. We asked folks around their drug treatment in the last year. 2/3 had none. And you saw the vast majority of folks were using near every day or every day. Highly likely that most of those folks have use disorder. And so the most common type of program was a methadone program, followed by buprenorphine, inpatient, outpatient, detox, and naltrexone, another medication for opioid use disorder. So you can see the types of drug treatment people had had in the last year. And also just, want to be transparent as well. There's folks who are still on these programs who are also continuing to use substances and also getting harm reduction. And that's great. It's great that people who are working on their recovery but are also using are getting harm reduction services. These services can and must overlap. I think we often think about, oh, you use harm reduction when you're using, and then you go into treatment and you don't need harm reduction anymore. We know that the average time to recovery for opioids and stimulants is 2 to 3 years, and that most people continue to use for part of that period of time. So we really need to be thinking about how harm reduction services and treatment and recovery support services can coexist. They can coexist in the same place. And it's also important for people who are providing one service or the other to acknowledge it's good if people are accessing these other services as well. So some of the treatment barriers that folks mentioned, and this is in response to the fact that 32% said there was a time in the last year when they tried to get help to stop or reduce their use, but they couldn't get it. So 1/3 of folks try to get care, but couldn't get it. This was work that Allison and others did to code narrative results. So I'm going to share with you the most common responses. I will also say, because of the way we asked this question, these are underestimates, highly likely, of the actual prevalence or how common these responses are. But the most common response, 23%, to the barriers they faced were availability and access problems. These were things like long wait lists, there were no treatment beds, no place to get meds for OUD, no identification, no help sort of navigating this entry process. 1 in 8 said that lack of transportation was a barrier. In my experience, working with folks, it's a lot higher than that, but we certainly know here that this was a common situation for folks. Sort of personal motivation, people just couldn't follow through, they were scared. Folks had just being homeless, no phone, no place to store belongings, or camp sweeps that disrupted their life and prevented follow through. There are issues around restrictive program issues or rules. Often that was around strict appointments or attendance rules. As folks know, in specialty addiction treatment programs and in primary care office-based settings, they have appointments and they have rules. And if you don't make the appointment, oftentimes they can't just take drop-ins, which is why I think these low barrier models that are all around drop-in care have really struck a chord with folks. They've really taken off. And then folks also talking about no insurance or the cost isn't too high. I will note that the substantial majority of folks, maybe Allison knows the proportion, is somewhere in the mid-80s, close to 90% of folks do have insurance who were surveyed, and the most common insurance was Medicaid or Apple Health. So priorities, again, asking folks, this was an open-ended one as well. What are the top needs in your life right now? Number 1 was housing, 44%. Income or a job, 15%. Stopping or reducing their substance use, 9%. Positive relationships, social support, friendship, love, 6%. Basic survival needs, food, water, personal safety, tent, tarp, clothing, 6%. Other needs mentioned include mental health supports, drug treatment, stability, transportation, sense of purpose, and help with legal issues or getting an identification card. I think this is super interesting. When I talk particularly with legislators and policymakers, they think of the most important thing for folks who use drugs is stopping their drug use. But when you talk with folks who are using drugs, there are other things that are more important and or preconditions to stopping their substance use. And so, you know, the solution to stopping drugs as drug use isn't just taking away the drugs or just getting treatment. It's also looking at the factors in their life that are contributing to the substance use and addressing those as well. Those are going to be important to support people who do want to stop the use, and also as they are working on their recovery to stay in that period of recovery as well. So some conclusions, and we have some time for discussion in a moment. So the high prevalence of stimulant use among people who use opioids really reinforces the need to address opioid use and related overdose risk and treatment within a polysubstance use context. I'll mention this as well. This comes up a lot. You saw that I think well over 80% of folks who use fentanyl also use methamphetamine, and a substantial minority of folks who use stimulants use opioids as well. So we can't just think it's one or the other and only offer services for one type of substance and not the other. As well as harm reduction supplies and services that address these different substances because there are different needs. And given the high prevalence of drug smoking and the greater health risks from drug injection, all these SSPs should be supported by policy and funding to distribute safer smoking supplies. Last year, Washington State Senate Bill 5536 was passed. It explicitly allows safer smoking equipment as well as drug checking services. So if it is explicit, it is unambiguous. Those things are protected in Washington state law. Housing is a crucial and substantial need. We've shown that with multiple different data points. Hopefully we don't have to reiterate that, but it really is really critical here. And most participants said the stable housing would have a positive impact on reducing or stopping their drug use. So that was a wonderful new question, I think, that we asked. I think it's very important to just get that explicitly. Most folks said the use would go down or they would stop if they got housing. Well, over half of folks said they needed, but did not seek health care. So a lot of folks needed health care but didn't get it. It also wasn't necessarily ranked as their sort of top priority. So I think that's really interesting. It was just 5% of folks. And again, as I mentioned, these efforts to increase availability of low barrier care, such as at health engagement hubs or other low barrier care settings, we really need to give equal access to those services, as well as addressing within that other survival needs, as well as navigators to access, help people access non-health services. I should note around sort of the low barrier buprenorphine or Meds First or health engagement hub model, the idea is that, of course, there are prescribers there, but very importantly, we have mental health care managers, nurse care managers, and care navigators. And we've been very fortunate in the programs that we've been able to manage and support to have folks with lived and living experience who have been working in these different roles across all of those roles, not just as care navigators. We've had folks who are in recovery also working as nurse care managers and as prescribers, and we welcome and embrace and learn from their efforts and expertise. So that's been very important learning for us. Syringe services programs can really be ideal places to provide primary care and or behavioral health care for folks because really importantly, they already have trusting relationships with staff. I just can't say enough about that. Folks who are so stigmatized and so marginalized, the default is to be treated poorly in care settings. So to have trusting relationships, which can take weeks, months, even years to develop, building on that foundation of trust and often love is really, really important. And we've shown repeatedly that when you build services there, people will take advantage of them in a really positive way. Folks are already coming to these sites for harm reduction and other supports and services that are much easier for them to access there than in traditional healthcare settings, as I mentioned. And I think really importantly, we see this over and over and over again. Our group is getting better about doing this. We have a lot further to go, but I will note that this survey really highlights the importance of involving people who use drugs in meaningful ways to design and deliver the services offered to them. People are people, they have individual preferences and needs. And so people who use drugs have clear preferences, insights, and innovative ideas for service models, and they're eager to share that information when given genuine opportunities for input and involvement. And that is in part in the Syringe Services program, but it also is in some of the qualitative work that we and many others do as well, as long as just sort of the feedback they're giving to the harm reduction programs and other providers out there. So when in doubt, listen to your folks and they will tell you what they need, as I think this survey hopefully shows. So here's our contact information. If you want to follow up with us later, I'm very open to that and would love to answer any questions or have any dialogue that folks would like to have.
I see one great question in the chat. Sina says, thanks for the great presentation. Do you foresee that the trend of the substance consumption change over time and switch back to injection as new drugs are introduced to the market?
In other words, we see folks moving away from smoking towards injecting.
Yeah.
Haven't quite thought about that before. I hate to anticipate the future. I think the short answer to me is no. I mean, I think the reason that people have historically injected drugs has usually been because that is the most efficient way to get an effect from that drug. And I don't know why a new drug would come on the market that would have that barrier to entry or that difficulty in use. Unfortunately, well, from one perspective, unfortunately, methamphetamine at 90 to 95% potency and fentanyl, given its high potency and relatively high purity, lend themselves to smoking. And drug manufacturers and drug trafficking organizations, they want as many customers as possible. And so I don't know why a drug would come on the market that would be injected. It's possible, maybe there's some new magical drug we don't know of that is so great via injection that it would drive people back to injection. But it's just hard for me to imagine that just sort of from my 30-year history in this work and even the couple hundred years of history we have around sort of manufactured and more recently synthesized drugs. So it seems like smoking is likely here to stay as a route. I just don't see folks likely going back to injection. I will say there are folks who wish they had reasonable quality heroin to inject. That felt better to them. They know that. They worked that. They could manage that. There's this idea about titrating or managing a dose of a substance. And with a lower potency substance, it can be easier to sort of adjust your dose. But with something so potent, particularly as fentanyl, it can be very hard to adjust your dose. And that is a great concern to folks. So I do think that something should happen in the market to make something that is somewhat less lethal and potent than fentanyl, because it can't be controlled at all. And it's leading to just severe mortality.
Next question is also related to smoking. Jim Duffy asks, any indication that smoking rather than injecting affected overdose rates?
Yeah, great question. These data definitely cannot answer that question around overdose rates. I think the population level data around what we're seeing with mortality and that the majority of people who are dying are smoking drugs tells us that smoking drugs is not safer. And when I talk with pharmacologists and addiction medicine physicians, I'm neither of those things. But given the potency of methamphetamine and given the potency of fentanyl, the chance of smoking being meaningfully or significantly less dangerous for overdose than injecting is low. Said another way, smoking is still a very high overdose risk. It's a very important risk reduction when it comes to infections, but I have not seen any evidence, and I don't think there is any evidence. I would be surprised if there becomes evidence that shows that smoking is meaningfully safer than injecting. It's a really important question because a lot of folks think that. And we used to say that, and I will say one other thing, and please, with heroin, that wasn't true. With heroin, particularly West Coast black tar heroin, smoking heroin, due to the properties of heroin and the properties of how heroin was smoked and metabolized, was safer than injecting. That was true with heroin. It does not appear to be true with fentanyl or methamphetamine.
I'll add, we have a few insights into perceptions around this from qualitative interviews that Teresa Winstead and Everett Maroon and I did now 18 months ago, where people perceived that smoking was a lower risk than injecting. However, they knew people who had overdosed while smoking. So I think there is still really important education for people around overdose risk and smoking. And maybe the risk is slightly lower, hard to say, but we know overdose is still highly possible, even with smoking. Maybe it's slightly easier for people to measure the amount, but with the huge variability of fentanyl, it's still really risky from an overdose perspective.
And I will just share with folks, the King County Medical Examiner for over a year has been tracking the probable route of administration for substances involved in overdose deaths, and it is predominantly smoking.
Anyone else have any other questions? Caleb and I covered, we both talk fast. So we have plenty of time for questions or discussion. Susan or Allie too, if there's things. Oh, chat has been disabled for attendees, so we can only use the Q&A. I'm so sorry. Either I will fix the chat. Thank you. My colleague Meg Brunner just Slack messaged me to know we had accidentally disabled the chat. Okay, we do have a question from Jamie. I'll see if I can fix the chat. I know the survey probably can't really get at this directly, but do we have any info on whether people are using drugs in the community by an inhalational route are less likely to seek services from an SSP? So are smokers less likely to go to SSPs?
All I know is that they are coming. So, I mean, I don't know, Jamie. But I mean, I think it is stunning that the sites that don't even offer safer smoking supplies still have a lot of folks who are coming in who smoke. And I don't know how much of that is folks coming in to get naloxone or other supplies or other services. But I definitely think that there's a desire to expand smoking supplies across the state at more exchanges. And I will also say there are some counties and health departments that are blocking that. So that is persisting. There are places that want to be distributing safer smoking supplies, and they are getting blocked on that. Generally more by internal sort of policy decisions, not by the law at this point. So we certainly think that offering broader array of smoking supplies is really important. And so I think, Jamie, like, empirically, people who smoke are coming to SSPs. Are they less likely because we're calling them SSPs? Maybe. But I also say that, and there's a lot of conversation among harm reduction programs whether they still want to be called syringe services programs or not. Some do, some don't. So I'll just note that as well.
Another question from Regina. This might be an obvious question, but I'm brand new to Washington and fentanyl is a newer thing for me to be working with clients about. I always get asked, why is there fentanyl in cocaine, weed, anything non-opioid? So I guess I just don't know how to answer that. To my understanding is that it's more efficient to cut with. Is that wrong?
What I would say, the simple answer is we rarely see fentanyl in other things. We've never seen it documented in cannabis. We've heard about it. I know there's been some very largely publicized stories about that. It's not been documented. We very rarely see fentanyl in things that are sold as heroin, cocaine, or methamphetamine, but it's very uncommon. It's much more common on the East Coast. And we had a meeting this morning. We often are hearing this. You may see up to 20% of stimulants on the East Coast that have fentanyl in them, or even vice versa. It's very rare here, low single digits. So part of that is there's word spreads among folks that may not be accurate. And also that we're extrapolating for what's happening on the East Coast and assuming that's what's happening on the West Coast as well. And that may not be true.
Yeah, I think it's really important to note that the drug supply is really variable by geography, even within small areas. As Caleb pointed out, BC, although a near neighbor, has pretty different drug supply than we do. So if you're reading news reports about what's going on somewhere else, it may not be relevant here. And that's why it's really important that we have drug checking programs, here in Washington State that can help inform what's actually in the drug supply. And I have finally we have the chat enabled. I'm really sorry. I think it's the default for Zoom webinar to not have chat. And I was trying to encourage you all to use it when you couldn't. We have some nice comments there. No verified reports of fentanyl in cannabis. Most use is co-use, not unintentional exposure. And there has been a lot of talk about fentanyl being cocaine or crack.
So I do want to mention that.
Yeah.
This is very important. So you bring up a really important point. So a lot of the fentanyl that's out there now originally really was in these blue M30 tablets, and they're still out there. But we're increasingly seeing it in powder and rock form. So there's something that certainly could look very much like crack or cocaine that actually is fentanyl. So it's less that it was necessarily sold as cocaine or had cocaine in it, but the appearance could be similar. And that is very important for people to be aware of, that there's a lot of powder and rock or crack form of, rock form of fentanyl out there. And that is very high potency. In the medical examiner in King County, again, they've tracked over the last year among a small number of cases, about 15 per period, but a pretty substantial increase in the purity of fentanyl in powder and rock form. We're talking 40, 60, 80% fentanyl in those forms, as opposed to pills where it's about 2%. So I don't want to get stuck in semantics. People should definitely be concerned about what's out there. And there are things that look like cocaine and maybe even look vaguely like methamphetamine that actually do have fentanyl in them. That's a little bit different than the cocaine all having fentanyl in it. But these are interrelated issues. I appreciate you raising that. And I will say it's interesting what Regina was just noting about. It's interesting compared to what you hear about in the media and on the streets. Yes, so we are happy to share with you the best evidence-based information that we have. It does not always align with what you will hear in the media.
The other thing is that it's important to, like, we are talking about an illegal drug supply. We're not talking about things that are made in a pristine lab. So sometimes fentanyl can get, if someone is producing, bagging cocaine and fentanyl in the same place, fentanyl could get into cocaine, potentially unknowingly. Like, mixing can happen. It's not happening in like a really pristine regulated setting. This is the risk of the unregulated drug market, is you don't always know what's in things. You don't always know how strong or weak they are. It's not like taking a Tylenol and you know exactly what's in it. So there definitely been cases where someone thought that they had cocaine and it turned out to be have fentanyl in it or to be fentanyl. So much more common with powders than with things like meth, which I think the drug checking data show that stimulants are pretty much, meth is meth in Washington state for the most part.
Yeah,
And then
there's a question from Stephanie there. It says, what are people smoking with if they do not have the safe smoking supplies? And the answer is essentially usually foil, tin foil. And what makes the supplies they're using unsafe? Great question as well. Couple of things around that. One, people may be much more likely to get burns if they're using things like foil to smoke off of versus a pipe or having a mouthpiece, so they can get burns. And burns matter because it hurts, but also because it can cause cuts, which is in a place where infection can enter. So that's very important. And then also people are maybe sharing that equipment. So it's both having the supplies, but also having your own supplies. That is very important so that people aren't sharing. So those are great questions. Thank you.
And by infections, it can be, bacteria. It can also be hepatitis C, which is a bloodborne pathogen that can be spread even by sharing smoking equipment if people's lips are bleeding. So that's an important thing that we want to pay attention to. And I think related, we have a nice comment from Teresa Winstead, our colleague. I think we saw in our qualitative work that people felt it was easier to feel like they have more control while smoking, but the risk for overdose remains due to the unregulated, unpredictable fentanyl supply. And we can emphasize these things regarding safe smoking: go slow, do a test dose, never use alone.
And
So
some folks definitely have
messaging.
reported that it was, they could actually easier control their dose if they were smoking a pill off of foil, because they're only getting exposure to it while they're heating it. So they could get sort of a small dose off of that. Whereas with injecting, it might actually be harder to control the dose. So there are ways that people can sort of monitor and regulate the dose with smoking.
And Kelly adds, doesn't even need to be bleeding. HCV, which hepatitis C virus, can be transmitted by microscopic blood exposure, non-visible blood. Yeah, it's a very pesky virus in that way. And we have a question from Daniel Raymond. Curious if there's any data to indicate whether people who solely primarily smoke drugs engage with SSPs less frequently, more frequently, about the same as people who inject drugs.
Great question. And hello, Daniel. And I don't know. We'd have to, instead of doing what we're doing here, which is sample people at the Syringe Services program, we'd have to go to folks out in the community who are using substances and ask them about their use of SSPs. I think there may be data from the NHBS survey that Sarah Glick has. Actually, they probably can answer that question, but I don't know the answer to that. But that's something I'm happy to try to track down. It's a wonderful question and very important in this instance. So,
any other questions, comments, anything? Susan, are there any insights you want to share or things you found interesting?
You guys are doing a terrific job.
These are great. These are wonderful questions. These
They're
are
really good questions.
really, you're hitting a lot of really great points here. I really appreciate it. I just appreciate the opportunity for sort of the dialogue on it. It is complicated. We certainly don't have all the answers, but I think, asking folks who are using these services and are using substances, what's going on and what they need is invaluable. I'll share that in my work, this is the most probably powerful data that we've ever collected. It's just really, really important. It gives voice to those folks who often don't have a voice. It gives data to syringe services programs and harm reduction programs that need their own data. They need to know it for their own programming and also for their own education and their communities. And that's something we're very happy to partner with them on. And then also really, these data we are readily sharing and we'll share with legislators and policymakers as well, because this really is important to inform work. And I think has helped inform the work. I mean, I think a lot of the low-barier buprenorphine and the health engagement hub work that is really motivated and spurred on by these types of findings. And so we're just really, really thankful to the participants in this and all these harm reduction programs across the state, and then also folks here at UW. It's pretty amazing enterprise, and we're really, really fortunate.
We're getting some nice love in the chat. Wonderful work on this. Thank you, very insightful. This was an inspiring presentation. Thank you very much. I'm inspired by the changes and the results. And we do have a question from David Fine. Oh, and then from Megan. We'll do David and then Megan. There can be a perception that people are refusing services. This data seems to contradict that notion. How can I use this data to counteract that notion that people aren't interested in participating in services?
I mean, to me, it's as straightforward as that. In 2015, when I first shared this data with the legislature, and I said, 80% of folks who use opioids want to stop or reduce their use. Legislators were it wasn't they didn't believe it, they were just surprised, because their perception, and I think it's important for us to all be mindful of this, that like sort of the general perception is you look at in public and you see people using substances and it doesn't look like they want to stop using, they're using. And not understanding the social determinants of health and the circumstances of that person's life, and the using in that moment for a lot of really complex reasons that you cannot see. So being able to document the fact that people say they want to stop or reduce their use and they want the most evidence-based services, I think it's as straightforward as that. I mean, we've been able to use that to build interest, demand, and capacity for low barrier services. So I think that's super important. And for Megan, hello, Megan. Any tips on how to get local leaders to actually take an interest in viewing this data? Rent a biplane? No, I'm kidding.
It's really hard to do charts and graphs.
That's true. I mean, I think part of this is, I think, putting together, three bullet point highlight that you think is meaningful to them and just sharing that, or getting your partners like, emergency room physicians or EMS or fire to be able to share these data and say, hey, we're seeing these problems as well. Folks want to do something. We need to do something. So trying to think about your partners and stakeholders in the community who might be good messengers of these data. I think that's something to think about as well.
We have a nice question from Robert. I'm curious if there are significant behavioral changes with the increase in smoking. Anecdotally, is it more a social group activity? Is this impacting ODs?
These are great questions. I think the answer to that is what we're hearing repeatedly, both here and in San Francisco and other places, is it is more social. And I think that brings up a couple of issues we've heard more anecdotally and qualitatively, but they're from folks who have a lot of history and who I trust. It is more social. That can actually be a challenge for folks when they're trying to sort of enter into recovery, because they're trying to reduce their use, but their social network is all using. So that can be really challenging. I think also the fact that smoking is easier to do, people may be more comfortable using in public than they would be injecting. And so there may be actually more visible substance use, even if there isn't more substance use. And then another layer of your question is that social component may well be reducing overdose risk. And in fact, we know for folks who go into supportive housing, overdose risk can really go up because they're in isolation, even as they're using. Obviously, housing is a good thing. And there's a lot of work that we and others are doing around how to get more supports in and how to get more overdose prevention resources and observation of folks so that they don't have those overdoses. But there are, to your point, some aspects around smoking that can be more social, and it can be protective in some ways if there are other folks around. So that's a really great point. Thank you.
I'm just getting more compliments. They're just rolling in. So no more questions, so people are putting more compliments in the
Well,
chat.
Allison and I prefer chocolate chip cookies. We like compliments, thank you, but also chocolate chip cookies.
Zoom doesn't have that capacity yet, so. Well, if there are no more questions, I'll just let everyone know we will be posting this later today probably later today, at least tomorrow, on Stop Overdose on our videos page. You can check out the report on our ADI webpage, or if you can't find it, just send me an email and I will send it to you. And back to Megan's question, one good way to get leaders engaged, you can give them the handout we made for participants. It is at a grade 6 reading level, so accessible to all and has pictures. So, I mean, we do put it in that format so that people can easily understand the information, so that they can grab it, so that busy people can understand what we're trying to communicate. So feel free to share that handout. Our colleague Erin McGraw put it together for us, so it looks pretty snappy. But yeah, if you can just get that one handout in front of people, that's a great place to start. And yeah, as I said, recording will be posted. Everything's posted. Meg is shared the report link. I think that's all, but really want to thank everyone for participating today.
That's great. Thank you, everybody.